One of the themes from ASH this year is the quadruplets therapies in induction for myeloma, especially newly diagnosed myeloma, and where that fits in. Before this, really most of the data that we had came from two studies. One was the CASSIOPEIA study, which was a phase 3 trial comparing Dara-VTD versus VTD in the transplant-eligible setting. And then we also had the randomized phase 2 GRIFFIN trial, whose final results were published recently. And one thing that was interesting about the GRIFFIN trial is that, it was designed as a randomized phase 2, looking at the rate of stringent CR as the primary endpoint at the end of consolidation. And it actually did not meet its primary endpoint. But when you look at the progression-free survival curves of Dara-VRd compared to VRd, you see this very prominent distinction between the curves, where Dara-VRd is showing that it is statistically superior, associated with superior PFS compared to VRd. And, we actually now get confirmation of those results. One of the late breaking abstracts that's going to be presented at ASH, or was presented at ASH, is the PERSEUS trial looking at Dara-VRd versus VRd. And, what we are really happy to see is that when you have a primary endpoint of PFS, we see the same thing, right? We see actually almost identical 48-month PFS with Dara-VRd, which was 84.3% versus 67.7% with VRd. And overall survival is not different between the arms, which we sort of expect at this point. I would call it immature. But, one of the interesting things about Perseus was that the VRd schedule was given a little bit differently than in GRIFFIN. So the bortezomib was given twice weekly, but the cycle was actually a 28-day cycle. So lenalidomide was given on days 1 through 21, and dexamethasone was given in 2 courses, days 1 through 4, and then 9 through 12. But I think the main thing here is that we see that quadruplets really should be here to stay, regardless of cytogenetic risk. Even the standard risk patients stand to benefit greatly from it. We also have real-world data from Emory. Dr. Joseph, in abstract number 647, shows that with 326 real-world patients treated with Dara-VRd within the Emory network, you see also that PFS is already superior, associated with superior PFS when you get Dara-VRd compared to VRd that was done there. And what's interesting about that abstract is that the way that they gave Dara-VRd was 4 cycles, a transplant. But then following transplant, they got rid of the consolidation piece with 4 drugs, like was done in GRIFFIN. And actually, for standard risk patients, just continued lenalidomide. So this was potentially a less aggressive or less intensive regimen, and we still see a benefit. So just 4 cycles of Dara, when you add it to VRd, may make a huge difference for transplant-eligible patients. But we also have a plenary session where we're having IsKia-KRd versus KRd and EMN24. And we have Dr. Guy who's going to be presenting that. And this was 4 cycles of each regimen sandwiching a transplant. So 4 of KRd or IsKia-KRd transplant, and then the same 4 cycles afterward. And the primary endpoint here was MRD negativity at 10 to the minus 5 after consolidation. It was done in an intention to treat fashion. And what you can see is that the rate of MRD negativity was in fact superior for IsKia-KRd compared to KRd. We don't have PFS differences yet. It's only 20 months of follow-up. I think with further follow-up, we may get some more information on that. But I think what this really shows us is that with a weekly Carfilzomib, using this intention to treat analysis, we get impressive results, especially on the MRD negativity side, which I think will translate to a PFS benefit. The other interesting abstract that looks at the quadruplets is the GEM 2017 FIT study. And this looked at transplant-ineligible patients. And there were 3 arms, but one of the arms was Dara-KRd for 18 cycles. And then MRD sort of guided the next phase of therapy. Patients who were MRD positive would continue with daratumumab and lenalidomide, and patients who were MRD negative would go on to observation. The median age in the study was actually 72 years old, which is impressive, and that's reflective of the fact that this is probably a truly transplant-ineligible population. This was not cherry-picked. And a third of the patients were over 75. And you see a very high rate of MRD negativity, not only at 10 to the minus 5, which was 79%, but also at 10 to the minus 6, which was 74%. The PFS, the 18-month PFS, was 87%. And this is where it gets interesting, and I think we're going to need longer follow-up, because that was not different than the KRD arm in this study, which was also 87% for the 18-month PFS. But actually, the 18-month overall survival seemed to be slightly lower for Dara-KRd. And this was particularly due to infections that occurred. And so some have questioned whether, the use of Carfilzomib here in older patients might not be such a great idea. And within that context, I wanted to share our abstract, which was is being presented as a poster, and it's abstract number 4747. And this was Dara-KRd for 24 cycles in newly diagnosed myeloma, but we did not exclude based on transplant eligibility status. So these were patients that could have been eligible or ineligible for transplant. And our Dara-KRd schedule was also a little bit different. So for the first 9 cycles, patients would get, or first 8 cycles, patients would get twice weekly Carfilzomib on days 1, 2, 8, 9, and 15 and 16. And then for cycles 9 through 24, it was every 2 weeks. So days 1, 2, and 15, 16. And the primary endpoint of our study was a stringent CR and or MRD negativity by NGS at 10 to the minus 5th. Specifically at the end of cycle 8. And in our data set, we had 42 patients that were enrolled. The median age was much younger than some of the other ones I've shared with you, which was 58, the range being 39 to 79. But 57% of our patients had high-risk disease by some account, most of which, were accepted, high-risk cytogenetic abnormalities, including 24% of patients who had 2 or more high-risk cytogenetic abnormalities. 76% of the patients, or 75% of the patients, met the primary endpoint, which was stringent CR and or MRD negativity at 10 to the minus 5. And, in particular, we did see lower rates of MRD negativity than what I've shared with you, in the other studies. At 10 to the minus 6, we had 53% that achieved this rate of MRD at 10 to the minus 6 as a best response. So, when we look at progression-free survival, though, we see very high numbers here. So the 3-year estimated progression-free survival was 85%. For this study, and the 3-year overall survival was 95%. In fact, the only 2 patients that died on the study died early from rapidly progressive disease. And when we look at stratified by high-risk cytogenetics, the 3-year overall progression-free survival for patients with standard risk or 0 high-risk cytogenetic abnormalities was 100%. And it was 92% if the patient had 1 high-risk abnormality, and it was 60% for those with 2 or more high-risk abnormalities. And this is really key, because what I think it's telling us is that quadruplet therapies work really well for patients with 0 or 1 high-risk abnormalities. We see that across the board. But patients who have 2 or more high-risk abnormalities, we really need to do something better for these patients. I don't think that transplant actually changes things. I think we see the same numbers whether you continue extended induction, like in this case, or you do a transplant instead. Last thing that I wanted to share about this abstract is that we also included data on mass spectrometry. And this is using a peripheral blood test to look at MRD. And we looked at 2 different methods. One method is called the EXENT system. This is both through the binding site. And the other one was called liquid chromatography mass spec. EXENT is easy to do. It's automated. It's quick. LCMS is a little bit more laborious, but it is more sensitive. And what we found in our study is that 64% of patients actually were negative by EXENT at some point during the study, and only 31% were negative by LCMS. But here's what's really interesting. When you stratify patients' PFS by their mass spec status as a best response, EXENT negativity was significantly associated with superior PFS. And LCMS, actually not a single patient with LCMS negativity had disease progression on the study so far. So I think this is going to be a key marker for us to follow as time goes on.